Hello everyone, welcome to another video by Phoenix Medical Lectures. In today's video, we'll be seeing about arrhythmias. Arrhythmias is an abnormal electrical activity of the heart. How do we define arrhythmias? It is an abnormality of the rate, rhythm, sequence of conduction, and origin of conduction. How do we classify arrhythmias? We use rate. The normal heart rate is 60 to 100 per minute. So if it goes beyond 100, then we say tachyarrhythmias. If it is less than 60, then we say bradyarrhythmias. So this tachyarrhythmias is further classified into supraventricular tachycardia and ventricular tachycardia. So first we'll see about supraventricular tachycardia. It is further subdivided into sinus tachycardia, wherein the SA node fires abnormally. So that is the sinus tachycardia. Second one is the focal atrial tachycardia. So these two types, focal atrial tachycardia and multifocal atrial tachycardia, both are similar in the sense that the ectopics in the atrial wall will fire abnormally, and that will reach the AV node before the signals from the SA node reaches the AV node. This is similar for both. The only difference is that the foci is single in focal atrial tachycardia, whereas there are multiple foci in multifocal atrial tachycardia. The next one is again due to atrial ectopics, but these abnormally firing ectopics are very fast, so that causes atrial fibrillation. Next is atrial flutter, again caused due to atrial ectopics, but which is present near the tricuspid valve. Another one, commonly known as the paroxysmal supraventricular tachycardia, contains two different types. One is AVNRT, the other one is AVRT. AVNRT is the atrioventricular node reentrant tachycardia, and AVRT is atrioventricular reentrant tachycardia. So the AVNRT is when there's a re-entry circuit current in the AV node, which causes tachycardia. And in AVRT, there is a re-entry current between the atria and the ventricle, which causes tachycardia. These are the 7 types. So this AVNRT and AVRT together, we call it as paroxysmal supraventricular tachycardia. So we've seen about supraventricular tachycardia. Coming to ventricular tachycardia, we divide it into monomorphic ventricle tachycardia and polymorphic. So monomorphic is when there's only a single irritable area, okay, whereas polymorphic is when there's more than one irritable area, which will lead to tachycardia. So why have I mentioned that there's a normal QT interval? Because there's another subtype which is known as torsades de pointis. Torsades de pointis, which is also a polymorphic ventricular arrhythmia, but the only difference is it has a prolonged QT interval, whereas here in polymorphic ventricular tachycardia, there is a normal QT interval. Polymorphic ventricular tachycardia along with a prolonged QT interval is something that is known as torsades de pointis. And then the final one is ventricular fibrillation. So there's again multiple ectopics in the ventricle, but there is rapid firing. Like we saw with atrial fibrillation, again this atrial ectopics, but that is really fast. Similarly, ventricular fibrillation, again ventricular ectopics, but that will have a rapidly firing. So we were seeing about tachyarrhythmias. Coming to bradyarrhythmias, that is subdivided into sinus bradycardia, first degree, second degree, and third degree heart blocks. There's another syndrome which is known as the sick sinus syndrome, which is a combination of both bradycardia and tachycardia. This is caused due to a dysfunction of the SA node. There's a dysfunction of the SA node which will cause an arrhythmia, and this will cause bradyarrhythmias. So that type of bradyarrhythmias is called as sinus bradycardia because the SA node is involved, which we already saw. So this SA node dysfunction leading to sinus bradycardia will lead to a compensatory mechanism by the atria, which causes atrial tachycardia. So that the type of tachycardia is atrial flutter or atrial fibrillation. So, what are the causes of tachyarrhythmias and bradyarrhythmias? So, the cause of tachyarrhythmias is increased automaticity, triggered activity, re-entrant circuit. And then for bradyarrhythmias, there's a decrease in automaticity and conduction block. We'll see one by one. First is automaticity, which we saw for both bradycardia and tachycardia. So here we see the parasympathetic nervous system, especially the cranial nerve 10, which is a vagus nerve, it leads to an increase in acetylcholine, which will decrease the heart rate. On the other hand, there is the sympathetic nervous system, which leads to an increase in epinephrine and norepinephrine, which will lead to an increased heart rate. So the vagus, which leads to an increase in acetylcholine and a decrease in heart rate, that is a decrease in automaticity, while the sympathetic nervous system, which causes an increase in heart rate, is an increase in automaticity. So it's the difference between the parasympathetic nervous system and the sympathetic nervous system. So we'll see the causes for a decrease in automaticity. A decreased automaticity is due to an increased vagal tone, like we already saw. So how does the vagal tone increase? So due to sleeping in athletes and in inferior wall MI due to a block in the right coronary artery. And then there's conduction block due to beta blockers, calcium channel blockers, and digoxin. The third one is metabolic activity is decreased, hypothermia, hypothyroidism. And then increase in potassium, which is hyperkalemia, might also cause a decrease in automaticity. And then increased intracranial pressure, that might lead to brain herniation and might lead to something known as the Cushing's triad, which is a decrease in heart rate, hypertension, and irregular respiratory rate. So these are the causes for decrease in automaticity. Coming to increase in automaticity, it is due to the increased sympathetic nervous system tone, which might occur due to hypovolemia and then hypoxia. Hypoxia due to decrease in RBC, lung disease, and pulmonary embolism. Sympathomimetics and pain or anxiety might also lead to an increased sympathetic nervous system tone, thereby increasing the automaticity. The second one is increase in metabolic activity might also lead to an increased automaticity, which is due to fever or hyperthyroidism. So this is about automaticity. So if there is a decrease in automaticity, then that causes bradyarrhythmias, and if there is an increase in automaticity, that causes tachyarrhythmias. The second reason for tachyarrhythmias was triggered activity. So we divide triggered activity into two types: early after depolarization and delayed after depolarization. So the early after depolarization, we'll see the causes: antiarrhythmic drugs, antibiotics, antipsychotics, antidepressants, and antiemetics. These are the main cause for early after depolarization, where there's a decrease in potassium and calcium. Delayed after depolarization, the causes will be ischemia, hypoxia, inflammation, stretch, where there's dilated cardiomyopathy, mitral regurgitation, and then there's an increased sympathetic nervous system tone and digoxin toxicity. These are the causes for delayed after depolarization. So we saw the causes. So what is early and delayed after depolarization? Depolarization is occurring. So the tachyarrhythmias that occurs early in the depolarization, then we call it as early after depolarization. Whereas if it occurs post depolarization, after depolarization, then we call it as delayed after depolarization. Okay, so next, another reason for tachyarrhythmias was re-entrant circuits. Re-entrant circuits is when there is two different conduction that we're going to see here. So first we'll see the causes for re-entrant circuits. One is AVNRT, AVRT, which is paroxysmal supraventricular tachycardia, and then ventricular tachycardia, ventricular fibrillation, atrial flutter or fibrillation. These are the causes of re-entrant circuits. So the main cause for re-entrant circuits would be paroxysmal supraventricular tachycardia, which we divide as AVNRT and AVRT. First we'll see about atrioventricular re-entrant tachycardia. There is an accessory pathway here there is an accessory pathway which is also known as the bundle of Kent. This accessory pathway is commonly present in Wolff-Parkinson-White syndrome. So what happens is there is two different types of AVRT. One is orthodromic, the other one is antidromic. There's orthodromic and antidromic. So first we'll see about orthodromic. So in orthodromic, what happens? First, see this green colored pathway. So the normal conduction pathway remains the same. From SA node it goes to AV node, from AV node to bundle of His in the bundle branches. But after that, it goes through this accessory pathway, the bundle of Kent, and it again comes back to the AV node and a circuit is formed. Okay, a re-entrant circuit is formed and this causes tachycardia. So what is the second type that we saw? Antidromic. So antidromic is just the opposite. What happens? Directly from SA node, the current goes to the accessory pathway, which is the bundle of Kent, and from there it comes down and it reaches the AV node. From AV node, it again goes to the bundle of Kent and a re-entrant circuit is formed. So that also causes tachycardia. Okay, so the difference between orthodromic and antidromic is orthodromic will cause a narrow QRS, whereas antidromic will cause a wide QRS, and orthodromic is the most common type. Coming to AVNRT, which is atrioventricular node. So in the previous one, it was just atrioventricular. This is atrioventricular node re-entrant tachycardia, where what happens is from the main causes for AVNRT here might be due to any scars or any fibrosis, which causes a block here. So it just causes a slowdown in the conduction pathway. So what happens? From the atria, signals are coming towards the AV node. So there's two different pathways, which is alpha and beta pathway. This is the AV node. So from the alpha and beta pathway, we have a slow conduction in the alpha pathway, whereas a fast conduction in the beta pathway. Anyway, it is going to go to the bundle branches. From the atria, when this comes down, it comes a slow conduction occurs, whereas here there's a fast conduction and then it goes to the right and left bundle branches, after which it a little bit also goes back to the alpha pathway, which is cause for the cancelling of the current. So what happens in alpha pathway, though the conduction is slow, the repolarization will be short, whereas in beta pathway, though the conduction is fast, the repolarization is going to take longer because of this, because the current is cancelled here. So what happens after that, again signals are passed and there's a short conduction here. Repolarization is also short here. So another current can come by the time the repolarization occurs in the beta pathway. Before repolarization of the beta pathway, alpha pathway has another signal coming. So after this repolarization is ending, this current that passes through the alpha pathway, which normally goes to the right and left bundle branches, will also come back through the beta pathway, post the repolarization of the current that passed through beta pathway. So from here it goes normally to the bundle branches. Another thing that occurs, it comes back through the beta pathway. So this causes a re-entrant current in AVNRT. Okay, the next one is, so we had already seen all the causes for tachy is over. Coming to bradyarrhythmias, we saw that automaticity was a cause. Apart from that, the second cause was conduction block. So conduction block is when there's complete block of the AV node. Okay, so what are the causes? First is beta blocker, calcium channel blocker, and digoxin. Lyme's disease, which is a tick, it is caused due to a tick, and increase in potassium, which is hyperkalemia, and then inferior wall MI. These are the main causes. Apart from this, fibrosis and infiltrations, which is caused due to amyloidosis and sarcoidosis. Okay, coming to tachyarrhythmias. So how do we classify tachyarrhythmias? We basically classify tachyarrhythmias based on whether there's a narrow or wide QRS complex and whether it is a regular or irregular rhythm. So how do we say that a particular tachyarrhythmias has a narrow or wide QRS complex? The normal is 0.12. If the QRS is less than 0.12, we say it is narrow. If it is more than 0.12, then we say it is wide. So how do we count it? We have these small squares in the ECG, which if it is less than 3 small squares, then it is narrow. If it is more than 3 small squares, then it is a wide QRS. So coming to regular or irregular rhythm, so between two R waves, we see the distance. If it remains the same throughout the entire ECG, then this distance is normal, then it's regular. If it changes, then it is irregular. So this is how we classify tachyarrhythmias. So we'll see the causes of each type. First one is narrow QRS with regular rhythm. So there is narrow, wide, regular, irregular. We are combining narrow and regular. So what are the causes? First is sinus tachycardia. Second is focal atrial tachycardia, atrioventricular node reentrant tachycardia or atrioventricular reentrant tachycardia, and atrial flutter. These are the causes for narrow QRS and regular rhythm. We'll see one by one. First one is sinus tachycardia. So sinus tachycardia, the P wave, we see for the P wave. P wave is normal. Okay, it is upright in lead 2. So this is lead 2. In lead 2, the P wave is upright. If it is like that, and in AVR, the P wave is inverted, then we say it is sinus tachycardia. Rest, everything is normal. Like there's a P wave and then it is followed by a QRS complex, post which there is a T wave. All of it, it's normal. There is tachycardia, and in lead 2 there is an upright P wave, and in AVR there is an inverted P wave. Then we call it a sinus tachycardia. Focal atrial tachycardia is quite similar to sinus tachycardia. There is just one difference. In lead 2, we see here the P wave is inverted. Okay, there's an inverted P wave, whereas in AVR there is an upright P wave. And apart from that, everything is normal. There's a P wave, there's a QRS complex, and then there's a T wave. Everything is there. It's normal. But the only difference is in lead 2, there'll be a inverted P wave, and AVR there'll be an upright P wave. So it is just the opposite of what we saw for sinus tachycardia. It's just the opposite for focal atrial tachycardia. Thank you.